All right, good morning and welcome to Grand Rounds. If you're in the Tanglewood facility, come down because we got some new faces that are old faces to meet. So I won't say who that is, but come on down if you want to find out. This morning we have Dr. Mandeep Rana presenting and giving us a little bit about some neonatal seizures. I'm embarrassed because Dr. Rana gave me this bio that doesn't do her justice, but it gives us plenty of time for us to go over the material this morning. But she is Associate Professor of Pediatrics here at Carilion Clinic, Virginia Tech Carilion School of Medicine. She joined us last summer,
July.
As section chief after an extensive kind of bit of training. I mean, the brief training is she graduated from Sardar Patel Medical College in India and completed child neurology residency training here at Boston University Medical Center in Boston. After that, she did a sleep medicine fellowship at, I believe, Boston Children's, and then neurophysiology was at University of California, Irvine. Prior to that, she was at Boston University Medical Center, and then worked at Children's Hospital of Orange County and UCSF Fresno. She is, again, this is a very brief outlook, because you look at her, she is extensively published and continues to be very prolific in her pursuits of scholarly activities. She's really bringing some fresh ideas on building our sleep center concept here and building up a lot of the epileptology within Carilion Clinic. And we're so excited to have her this morning. Thank you.
Thank you, Dr. Hughes, for that introduction. Good morning, everyone here. Thank you for being here bright and early. Can all of you hear me okay? Back there? Yes. Okay. All right. So I have no disclosures that are relevant to this presentation. I'm going to talk to you about the science of neonatal seizures, which is what are the differences in neonatal neurophysiology that leads to seizure susceptibility in this age group. What are some of the etiologies, the semiology of neonatal seizures, classification of neonatal epilepsy syndrome that came out more recently, published by International League Against Epilepsy, diagnosis, and then we'll delve in a little bit deeper into the guidelines published by ILAE for neonatal seizures in terms of first and second line medications, when to discontinue these medications, especially in the acute symptomatic seizure cohort, and how important it is to treat the neonatal seizures, particularly the electrographic only seizures. I'm going to start with a case that we had in NICU a few months ago. This is a one-day-old female who was born at 40 weeks of gestation, who presented to the emergency room with seizure after being discharged less than 12 hours ago from our nursery. She was born to a 32-year-old female, and third gravida. Pregnancy was largely uncomplicated, and so was the delivery. She had APGARs of 8 and 9. She was feeding quite well before she was discharged. While in the emergency room, she had a couple of events that were described as perioral cyanosis, twitching motion of bilateral upper extremity, lower extremity shaking and spasms, and some nystagmoid movements that were concerning for seizures as well. She was afebrile in the emergency room. Her other vitals were stable. Her initial blood glucose was 40, but was repeated within a few minutes, and it was 51 without any intervention. Her workup, including CBC, electrolytes, cultures, were all negative. A lumbar puncture was attempted in the emergency room. It was initially unsuccessful, but later that was completed when she was in the NICU, and all the cultures were negative as well. The baby was treated with AMP and Genta and acyclovir pending these cultures. And the baby did receive a load of phenobarbital in the emergency room that led to transient resolution of seizures, but the seizures recurred And by the time I saw her for the initial consult, she was on phenobarbital, levetiracetam, and was continuing to have at least 5 or 6 seizures per day. And at the end of the seizure, she would have marked desaturation of the 70s, so requiring intermittent oxygen through nasal cannula. Otherwise, on exam, she was well appearing, feeding quite well. Her head circumference was in 25th percentile and had a non-lateralizing neurological exam. She did not have any neurocutaneous stigmata. There was no organomegaly as well. And of note, her family history was notable for maternal grandfather and maternal great-grandfather with epilepsy. So hold on to those thoughts and we'll come back to it at the end of the presentation. Neonatal seizures represent a neurological emergency, and prompt recognition, trying to understand the etiology and tailoring the treatment accordingly is really pivotal because a lot of these can be consequential. And neonatal seizures are defined as seizures in the first 28 days after birth. The incidence is 1 to 4 per 1,000 live term births, but the numbers are much higher in the preterm patient population. And depending on what study we look into, what methodology was used for that particular epidemiological study, these numbers in preterm infants can range anywhere from 10 to 100 per 1,000 preterm births. So why are neonates more susceptible to seizures? You can see in this graph that there is an imbalance between excitation and inhibition in this age group in particular. The excitation predominates over inhibition in a vast majority of the brain structures, including cerebral cortex, certain subcortical areas, limbic system. And on one hand, this imbalance is helpful to promote the rapid brain development that's occurring at this time. But on the other hand, it leaves the neonates extremely vulnerable to seizures. The major excitatory neurotransmitter is glutamate and acts through a variety of different ion channels and receptors, NMDA and ampine kinase. And the major inhibitory neurotransmitter GABA, interestingly, is actually excitatory in the preterm patient population. And this switch from excitatory to inhibitory does not occur until 28 weeks of gestation. And that too is not complete. It gets completed pretty much later on in life. So it's really not an on and off switch. It's more of a gradual transition that occurs from its excitatory nature to inhibitory in the neonatal period. And why is GABA excitatory in immature neurons? That's because of the differential maturation of some of the chloride cotransporters. The potassium chloride cotransporter in immature neurons is not mature, thus the chloride concentration within the neurons is much greater than the extracellular environment. So when GABA opens up the GABA receptors, there is actually an efflux of chloride out, leading to depolarization and thus excitation of the immature neurons. And in mature neurons, the potassium chloride cotransporter is well developed, thus the chloride concentration is less compared to the extracellular environment, and with opening of the GABA channels, chloride actually comes in, leading to thus inhibition or hyperpolarization of mature neurons. So all in all, neonatal brains are hyperexcitable because of excess glutamate acting through a wide variety of different receptors, and GABA, it's quite inhibitory and not as excitatory as it is in older children and adults, thus leading to that imbalance and vulnerability. Etiology of neonatal seizures. As you can see in this cartoon, a vast majority of the neonatal seizures are acute symptomatic, and this in of itself does not represent epilepsy. A small enough subset of these patients, depending on the extent of the insult, can have a direct evolution from acute seizures to symptomatic epilepsy, and a handful of those can quieten in regards to seizures, but go on later to develop unprovoked seizures and epilepsy. A subset of patients who present in the neonatal period can have neonatal onset genetic epilepsies as well, but this number is much smaller than the acute symptomatic seizures. And if we look into the etiology of acute symptomatic seizures, hypoxic ischemic encephalopathy is the leading cause for that, followed by vascular etiologies, stroke, hemorrhage, infectious etiologies, metabolic. Genetic and brain malformations account for the genetic epilepsy syndromes that present in the neonatal period, and these account for about 10 to 15% of all presentations. And as you can see in this diagram, there is a fair amount of overlap between different etiologies, meaning we should always be mindful that a child or a neonate who's presenting with seizures in the neonatal period can have a dual pathology as well. This was a study that was published a few years ago by Carilion in Pediatric, looking at the distribution of seizure etiology and burden. And on the x-axis, you can see the number of observations for each level of seizure burden, and on y-axis, the proportion by seizure etiology. And in this study as well, the number one contributor was HIE, followed by stroke and hemorrhage. And in of itself, these three contributed to about 75% of all causes, followed by a smattering of different etiologies, including metabolic, infectious, or genetic epilepsy syndromes. It is interesting to note that in some of the low-middle income countries, HIE still stands as number one etiology, followed by infectious etiologies. The stroke and the hemorrhage is sort of in number two or number three etiologies in the low-middle income countries, and part of that could be maybe there were not enough resources and all of those kids were not imaged, and that's why those numbers are not as clear or up as the second etiology, which is the infection and the population. What is the semiology of neonatal seizures? So we know that newborn brains are not myelinated. The myelination is only in the areas that is required for them to survive, which is feeding and breathing. And the dendritic processes and axons are all very immature, so the regional connectivity is also not well developed. As a result, generalized tonic-clonic seizures are extremely rare in the first month of life. And the most common seizure types are either focal or multifocal clonic. Rarely you can have tonic and myoclonic seizures as well. And some infants can also present as mouthing, eye deviation, apneas, and autonomic features as well. This was a study that looked at seizure semiology based on etiology. And as you can see in this cartoon, for acute symptomatic seizures with hypoxic ischemic encephalopathy and stroke, the most common seizure types were clonic seizures. For HIE in particular, more than half of these patients actually had electrographic only seizures, meaning there is no clinical manifestation and all you see in these patients is just seizures on the EEG. Whereas those who present with genetic epilepsy syndromes as their first manifestation in the neonatal period tend to have either tonic seizures or myoclonic seizures. So if you hear the term tonic, myoclonic, or epileptic spasms in the neonatal period, that is a big red flag pointing towards a genetic epileptic syndrome rather than acute symptomatic etiology. And this is really important because early identification of the seizure type can really prompt our workup, appropriate workup, and tailoring the treatment accordingly as well. So what are some of the neonatal epilepsy syndromes? ILAE came up with these two broad classifications of epilepsy syndromes that primarily present in the neonatal and infancy. The first group is the self-limited epilepsy, and as the name suggests, this is a group that where the seizures pretty much resolve in the first year of life. The second big group is the developmental and epileptic encephalopathies, or DEE, and as the name suggests, in these patient population, infants or neonates have an underlying developmental delay as a result of the underlying etiology, independent of the epileptic encephalopathy. So there is really a combination of two things going on, although they could just be the manifestation of the same underlying process. And then there are the etiology-specific syndromes, some examples of which can include pyridoxine-dependent epilepsy, CDKL5, glucose transfer defect, and such. And a vast majority of these etiology-specific syndromes that have an underlying structural or a metabolic defect have developmental epileptic encephalopathies, although some of them can have self-limited epilepsies as well. And if you remember from the older classification, the terms like benign neonatal seizures or benign neonatal familial seizures, those have been sort of reclassified into these categories of self-limited neonatal epilepsies. And if you remember the older terminology, the Otahara syndrome or early myoclonic epilepsy of infancy, those have been both lumped in this category of early infantile, developmental, and epileptic encephalopathy. And the reason for lumping them in this category was because our understanding into the genetic etiologies of these conditions has really evolved, and it didn't make sense to have different categories because of the fair amount of overlap in their clinical presentation. And this is a pretty busy slide, but I'll just try to put forward some differences and some similarities between these self-limited epilepsies on the top and developmental epileptic encephalopathies that present in the neonatal period. The seizure type for both of these groups could be either tonic, focal tonic with apneas, vocalizations, or multifocal myoclonic. And some of these can also present as what we call as sequential seizures, which I'll actually show you a video towards the end. And that, if you see that, that's really representative of some form of a genetic epilepsy. Etiology in the self-limited epilepsies, especially in the familial forms, is secondary to potassium or sodium channel mutations, whereas in the developmental epileptic encephalopathies is secondary to structural brain malformations and a whole host of other genetic etiologies. The EEG background in the self-limited epilepsies is usually normal, whereas in the developmental epileptic encephalopathies, you can often see burst suppression pattern or slowing of the background EEG. There is really no distinction between awake and sleep state as well. Prognosis is pretty favorable in the self-limited epilepsies, and in the early infantile developmental epilepsies, these seizures are pretty resistant to treat, and they have a fair amount of developmental disability down the line. And many actually don't make it after first year of life either. One interesting type in the developmental epileptic encephalopathies, epilepsy of infancy with migrating focal seizures, where these infants can have near continuous focal clonic or focal tonic seizures. And the background on the EEG, you'll see seizures starting on the right side and then starting on the left. So they sort of migrate back and forth, and even before one seizure ends, the second seizure begins. And these are more commonly secondary to KCNT1 mutation and some other sodium channel mutations as well. Coming to diagnosis, how do we diagnose neonatal seizures? When we have a neonate with Seizures, certainly the first thing to do is ruling out infection and doing the CBC blood culture, lumbar puncture, ruling out metabolic abnormalities, hypoglycemia, hypocalcemia. And EEG is really the gold standard for diagnosis of neonatal seizures due to a wide variety of different reasons. And one of the most important reasons is that in HIE, as we discussed earlier, a vast majority of these seizures are electrographic only, so you may not see anything on the outside, but if you put an EEG on, they could be having multiple electrographic seizures. The other important reason is that even in the eyes of an observed trainer, the movements that these neonates have can be very, very confusing. You know, they could have tremors or jitteriness or myoclonus or posturing, which is just very hard to tell by outside clinical exam that these are seizures or not. The other important reason for EEG is that there is a very common phenomenon that we see in this population called electroclinical uncoupling, which is you do not see any clinical manifestations on the outside, but the electrographic seizures are ongoing. And this commonly happens when newborns are treated with anti-seizure medication, especially phenobarbital. And the reason for that is because of the differential maturation of GABA receptors between the cortex and the subcortical regions. So the subcortical regions are suppressed, whereas the cortical GABA receptors are not, and you continue to see the electrographic and not the clinical correlate. And lastly, the EEG background can tell us a lot. If you see a burst suppression pattern on the EEG, right away you're thinking about just certain genetic epilepsy syndromes, and your evaluation and treatment sort of is geared in that direction. And burst suppression and persistent flat trace in a child with HIE can help us predict a neurodevelopmental outcome as well. And then other diagnostic modalities like getting a head ultrasound, which is pretty easy to be done at bedside, and cranial MRI certainly gives us more information about the brain structural development. And if you're thinking along the lines of more of a genetic or metabolic, then epilepsy gene panel or testing for a metabolic disorder are the key. Just to give you an example of what a normal neonatal EEG background looks like in a term infant, this is the left brain, right side of the brain. This is the coronal channel going from left to the right. You can see that there is a mixture of faster frequencies and some slower frequencies, but the background is really continuous. This is an example of REM sleep, actually called as active sleep in newborns. You can see again the background is continuous, but it is a little bit more attenuated compared to what it is in wake state. But there is a mixture of faster and slower frequencies, and you can see some lateral eye movements as well on the eye channels. This is an example of non-REM sleep, which is called as quiet sleep in newborns, and there's a burst of activity followed by some attenuation and another burst of activity, and this pattern is called as trace alternans. This is another example of abnormal EEG background of burst suppression, where you see complete attenuation, the background is less than 10 microvolts, and then burst as well. Another example of persistent burst suppression, persistent suppression without burst. Look at the treatment of neonatal seizures. And we'll look into the first line and second line and some of the other items listed here. The most important thing to know in the neonatal treatment world is that we have very, very little good quality data. If we looking into the first line anti-seizure medication in this population, there are only 2 randomized controlled trials, and the others are all either prospective or retrospective in some case series, which obviously is not a great data to look at. The first randomized controlled trial was actually 2 decades ago, published in New England Journal of Medicine, where they treated neonates with phenytoin and phenobarbital. And when these infants reached a certain level and were not well controlled, they were crossed over to the other medication. And as you can tell that in both the arms, in the phenytoin arm and in the phenobarbital arm, the treatment was effective only in 45 to 46% of the patients, so even less than half. This was a study that was done by Sharpie et al. And published in Pediatrics about 3 or 4 years ago. And the biggest impetus of this study was because Keppra or levetiracetam had become very popular, and it was being used in most neonatal intensive care units, back and forth, left and right, without much evidence, and just with anecdotal reports. So in this study, just because of that reason, they actually randomized 2/3 of the patients to the levetiracetam arm and the remainder in the phenobarbital arm. And the results are actually quite surprising and shocking, because in the phenobarbital arm, these kids received 20 milligram per kilogram per load, and 70% of the infants were seizure-free. Whereas in the Keppra arm, 21% were seizure-free. And when they received the additional 20 milligrams per kilogram load, it didn't really make a huge difference, only 28% were seizure-free. And in the phenobarbital arm, when they received the additional load, 80% were seizure-free. Now you could also argue, why is the difference? The study that we did more than 2 decades ago also used phenobarbital, and only 43% were seizure-free in this group, and in this group it was 80%. So the thing with this study is that this is a study that was done before we had the hypothermia protocol, so that was not being used in this patient population. And then the second is, there is no continuous video EEG monitoring. So the kids who were actually enrolled in these studies were those who had been seizing for a long time, were not picked up, and they were probably having electrographic seizures undiagnosed and untreated for a long time before they came into this study. So the later the infants go on for having seizures, there's less likelihood that they'll become seizure-free as well. So these studies really give us, quite informative understanding about the treatment as well. So the first line anti-seizure medication, phenobarbital, is the first line, regardless of etiology. However, if you're suspecting a channelopathy, especially due to family history and other seizure semiology, then of course a sodium channel blocker should be the first line anti-seizure medication. It's quite interesting, phenobarbital was first discovered in 1800s, and it started being used for seizures and epilepsy in 1910, and it still remains the first line seizure medication for our neonatal patient population. So pretty old-fashioned, but it works. And then looking into some evidence for second-line anti-seizure medication, there are just 3 randomized controlled trials, and all those 3 have a very low certainty because of the small numbers. So because of this, the ILAE had to send this question for Delphi, and it turned out that there was really no pick on the second-line anti-seizure medication. If the first line does not work, you can pick anything that's available in your arena. That could be phospheny, levetiracetam, midazolam. If you're in Europe, it could be lidocaine as well. But again, if there is a channelopathy suspected, certainly use sodium channel blockers. If a patient has an underlying cardiac etiology, use levetiracetam because of the cardiotoxic effects of phenytoin and lidocaine. What's the role of pyridoxine hydrochloride or pyridoxal phosphate? Again, there are no RCTs for this either, and most experts agree on this, that neonates who present with clinical features on the EEG that suggest of vitamin B6 dependent epilepsy, meaning burst suppression or slow background, certainly this trial to be given. And if the seizures are unresponsive to at least 2 well-tried medications, then certainly this is something can be considered as well. Is the reduction of seizure burden associated with improved outcome? So So that's actually the big question. How aggressive do we need to be in treating these neonatal seizures? We know from data, some of the data that's already been published, that a higher amount of seizure burden is associated with higher mortality, longer length of hospital stay, and perhaps an abnormal neurological outcome. But this is somewhat of a chicken or egg situation, because is it the worst brain injury that is causing the infants to have more seizures, or is it more seizures leading to worse brain injury? We have two randomized controlled trials looking at this particular question. One was done in Europe and one from the United States. The one in Europe took children with HIE of moderate and to severe degree encephalopathy. And in this group A, they treated both clinical and electrographic seizures, whereas in group B, they treated only clinical seizures. And it turned out that the median duration of seizure before these infants became seizure-free was much lower, to 196 minutes, whereas those where only clinical were treated, their median duration was 503 minutes. And when they compared or correlated with the seizure burden and the MRI score of injury, a certainly higher seizure burden was associated with a higher MRI score, and vice versa. So there is some indirect evidence that electrographic and electroclinical seizure burden is higher. It leads to higher MRI injury score. This study from United States and Washington pretty much looked at the same question, where the higher electrographic seizure burden was associated with lower cognitive and motor scores. And similarly, the higher seizure burden was associated with more severe MRI injury. So the consensus is that perhaps treating electroclinical and electrographic only seizures to achieve a lower seizure burden may be associated with improved outcome, meaning neurodevelopmental outcome, and perhaps subsequent reduction of epilepsy. The next big question is, because a vast majority of our newborns have acute symptomatic seizures, how long do we continue their anti-seizure medication? This study came out in JAMA a few years ago, looking at the comparative effectiveness. In this study, about 2/3 of the patients, about 64% of the patients went home with an anti-seizure medication, and the other 36%, their anti-seizure medications were discontinued while they were still in the NICU. And they followed this cohort at 12, 18, and 24 months, looking at their neurodevelopmental outcome. And you can see the blue box plots represent the ones who had anti-seizure medication maintained, and the orange ones where it was discontinued. There is a fair amount of overlap, meaning there is not a statistical significance in terms of how these kids developed, whether they were on or off anti-seizure medication. And then the other outcome was looking at the risk of epilepsy, meaning unprovoked seizures, and that was no different as well. 11% in the ones where these meds were discontinued, and 14% where the meds were maintained. So the current consensus is that once the acute symptomatic period and acute symptomatic seizures are ceased or stopped, and there is no evidence of neonatal onset epilepsy, anti-seizure medications should be discontinued before discharge home, regardless of MRI or EEG findings. So coming back to the case that we discussed earlier, I'm going to show you a video. So when I saw this baby, for the initial consult, I'll actually tell you what I saw. I was lucky enough to see the seizure at the bedside. The baby was very well appearing, but she had sudden tonic posturing of her both extremities. And then this was followed by some mouthing movements. She had then a loud cry, some vocalizations, and then started to have a clonic activity pretty randomly, either of right or left or her arms. And then she had a profound desaturation to 70%. So this was sort of the seizure that I observed. And this was very suspicious to me for what we call as sequential seizures, meaning there was a sequence of events that were happening during the seizure. There was really no one predominant manifestation, but rather a sequence of different manifestations. So I will show you the video.
Was there any color change?
Yes, so this is the left brain on the top, the right brain. It's a tonic posture of both activities at the same time. You to see some of the activity on the left. Textures, slightly to now the tonic posture is gone and she's having some autonomous. And then there, towards the end, there was actually a background suppression on the right. Would you like me to play again or again? Okay. Side, that they have more activity. Now there is a chronic activity, arms, legs. Towards the end, there's a suppression of the right background. And by the end of the seizure, I think she desatted here as well to about 70%, requiring oxygen. So with this kind of seizures that this child was having that was concerning for sequential seizures, I had a strong clinical suspicion for genetic-based epilepsy. So we loaded her with fosphenytoin, which is primarily a sodium channel blocking agent. And the baby's seizures stopped within 24 hours of receiving the load and E-blood maintenance therapy. We gradually took her off of levetiracetam and phenobarbital, and she continued to have a good seizure control. Prior to discharge, she was switched to carbazepine, which is an oral sodium channel blocking agent. And thanks to Dr. Dorothy, who was able to help us coordinate the genetic testing and CSF analysis for this child before she left, before she was discharged. Let me go back to my presentation. So her genetic testing came back positive for a pathogenic mutation in KCNQ2. And this is the deletion she has, likely leading to some haploinsufficiency or partial loss of function for the potassium channel ion. And this is a spectrum of disorders that can have either self-limited neonatal seizures to ranging up to developmental epileptic encephalopathy. And as I pointed out earlier, most of the time these are responsive to sodium channel blocking agents. And our patient, she's actually 5 months old now. She's developing quite well, achieving all milestones age appropriately. She's had an EEG after being discharged from the NICU, and that EEG is very normal. She's had 2 breakthrough seizures, one in the setting of being transitioned from brand name only trileptal to generic trileptal, and one in the setting of fever. But other than that, she's continuing to do well. So I think time is really going to tell which path she'll follow, whether she'll be in the self-limited neonatal seizure versus DEE. But the data that we have so far for her is actually looking good. that she might be in the self-limited neonatal seizure spectrum. All right, so some of the takeaways. Neonates are not just small children. They have unique aspects to their pathophysiology. 75% of the seizures in the neonatal period are acute symptomatic, and 10 to 15% represent the initial onset of a genetic epilepsy syndrome. And continuous video EEG monitoring is really our friend in the NICU. Phenobarbital, first-line anti-seizure medication, but if you suspect a channelopathy, certainly go with sodium channel blocking agents. For acute symptomatic seizures, prophylactic treatment beyond neonatal period is usually not recommended. And rapid genetic testing in neonatal epilepsies is really essential for identifying the clinical and therapeutic decision making. But of course, we still have a lot of treatment gaps in the neonatal seizures and neonatal epilepsies, and essentially more well-designed and well-targeted studies are required. All right, so audience response question. Based on the current evidence, what is the first-line medication for neonatal seizures? That's right, phenobarbital. What is the most common etiology for neonatal seizures? Number 4, that's right, hypoxic ischemic encephalopathy. Correct. Well, thank you everyone for your attention, and happy to answer any questions. Yeah.
So the study with Sharpie et al. In 2020,
Yeah.
In that study, did they analyze without HIE? Taking off patients with HIE and seeing in the other group whether levetiracetam or phenobarbital is better.
It didn't really substratify that. Yeah,
that would be
included all comers,
Yeah.
regardless of the etiology and term infants. Yeah.
Somehow I personally feel phenobarbital is best for HIE, but other subgroup we should do more studies.
Other meaning you're thinking about infectious etiology,
infectious stroke, and then like genetic epilepsy, always sodium channels are better.
Yeah, certainly for genetic epilepsies, if you're thinking along the lines of channelopathies, phenobarbital really does not help.
Yeah.
Or even if it helps,
worsens sometimes.
even if it helps, the results are really transient and not persistent. But then it also depends on the underlying etiology for some of these genetic epilepsies, because it's not always a channelopathy. Yeah, I think we need more data on that. The results for these are really all over the place and very nebulous.
Yeah, and then because of the high volume of HIE, everything goes into that favor.
Towards that, and most studies do not have a great distinction or a sub-stratification in these results.
And then I do have a question about this kid. Did you have a routine EEG, and did you see a theta 0.2 in the?
There was not a theta 0.2. So what Renita is asking is an EEG finding that involves theta frequency waveforms admixed with some sharp waves seen in patients with self-limiting epilepsies. There is not a great suggestion of that. This child had a normal EEG background with some excessive sharp transients during wake state.
And then for KCNQ2 mutation, doesn't that specific mutation say whether it will be benign or whether it will be developmental encephalopathy?
It does not say that. I think it has to do with the extent of involvement and the type of mutation, whether it is a complete deletion versus a missense or a frame shift. And Dr. Dorothy can add to that.
Yeah, I think that we don't have a lot of data yet for specific mutations in that gene and outcome. So one of the things that I struggle with on these genetic epilepsy reports is that we can confirm that there's a mutation that looks like it's going to cause a problem with the genetic function, but typically predicting how the patient is going to do is extremely difficult. And you don't know when you look at case reports, is that really reflecting like what's happening in the United States for infants? You know, if there's a case report, that kid could have randomly been selected for publication, and maybe there's lots of other people who never had genetic testing and you don't know that they also have mutations in that gene. So I think it's difficult.
And you know, some of the published reports for patients who have KCNQ2 but had self-limited epilepsy, and then the other cohort that had developmental epileptic encephalopathy, if you look into the detail of their mutation, they both had loss of function. But the extent of haploinsufficiency was the one that shifted them from, you know, one side of the spectrum to the other.
Maybe a jump on, since we have genetics and neurology in the same room. I had the opportunity to hear a discussion by a fellow, Stephen Kingsmore, who's I guess the head of the Ratty Institute of Genomic Medicine, and he was talking about the rapid genomic sequencing, and it kind of gave me a scary thing, the thought of what the future may hold.
Yeah, so that's a well-timed question. So we just had a patient admitted to our hospital where we were discussing about sending a rapid exome. So just to refresh the audience's memory, so a panel genetically is a pre-selected set of genes that's often targeted towards a particular problem, like you might send a Noonan syndrome panel or an epilepsy panel, and that's a preset set of genes. And typically a panel is going to be sent on the patient. An exome is an attempt to look at all of the coding regions of all of the genes, and this technology is improving over the last 10 years. And exomes work better when both of the biologic parents submit comparison samples, because then if something is found in the patient, then it's possible to check the parent. Is the parent symptomatic or not symptomatic? Does the parent have this genetic change or not have this genetic change? So the actual cost of an exome right now, it's like a cash price charged by labs like $15,000. And then exomes used to take 2 months to turn around. So now a couple of labs are offering exomes at gimmick pricing for $1,000 a patient. Some labs have started offering a rapid turnaround exome. The idea is that you send off this test and you're going to get results back in a week. So all of a sudden now we're talking about genetic testing. It's actually within a time frame that it might make a difference in the hospital course for this patient. So this is very exciting, and I think is going to be a real game changer in terms of medical care of some of our patients that are admitted to this hospital. So I actually last week started having some discussions with Dr. Algino about whether we could start having access to rapid exome testing for our hospitalized inpatients, because a genetic test that comes back 2 months later for a patient that was in the hospital, you did not need to send that in a hospital setting. But a week-long turnaround time for some of our patients, I think, is realistic for adjusting the care.
Yeah, these guys were, even getting down to like 48 hours or less.
Yeah, so, well, don't forget that we're in Roanoke, so the test has to go out to Chantilly and then to the special genetics lab, so that's already adding 2 days of transit time, assuming that it runs out the door with the courier right away when we draw it. Plus having parents available to give comparison samples. So, if they're at home in Wytheville and you need them to come up to the hospital to give their comparison samples, that's also a challenge. But just very exciting in terms of potentially arriving at a much more accurate diagnosis and maybe changing what medication you're going to offer the patient. So this is just huge, and it's coming.
And that's where we are heading, precision medicine.
I didn't mean to shift from the neurology, but it was actually in the context of
I think there's a lot of overlap.
earlier edition of what kind of testing.
Yeah, and if you look into the cost, I mean, I think I was at AES last year, and when they were trying to compare, the whole exome sequence costs no more than a brain MRI with contrast. So, and how many brain MRIs do we do? I mean, quite a lot. So it's no different from that. But it ends up improving patient care, helping us tailor our treatment towards in a more efficient way. I think it's worthwhile. And I think it's also important from the aspect that provides closure to some of the families where we don't know what's going on, even if the course overall is not looking great. So.
As a geneticist, I think that arriving at a genetic diagnosis for the patient when it happens often provides relief for families because often the parents are feeling guilty. It's something we did or something we didn't do. You know, I had a drink during my pregnancy or I smoked a cigarette. Is this what caused my baby to have horrible seizures? No, it was a genetic problem. It wasn't anything you did or didn't do.
Can you summarize what clinical features, if any, would make you suspect channelopathy in this child?
So it was the type of seizures that she was having. The seizure semiology, when I looked at the seizure semiology, that's what actually made me think that I'm not dealing with an acute symptomatic seizure here. I'm dealing with more like a channelopathy. And that was the sequence of events in her seizures that included a tonic posturing, then some automatisms, some mouthing movements, autonomic signs where she would desaturate, and then the clonic activity. Meaning there was really no one predominant manifestation in the seizure that we would typically have. It was just a sequence of events that this patient had. And that's, if we compare this to our acute symptomatic seizure kids, meaning in neonates who have seizures as a result of HIE or stroke, they're mostly clonic, so focal clonic or multifocal clonic. And that would be some of the most common presentations. But this kid had just this unique semiology.
Watching that video, unless I was watching that child very closely, I probably would have missed it.
Yeah, me too.
As a clinical, yeah.
Did we check, test for the parents? Any family history?
We did send the testing for mother, father, and grandfather.
Yeah, turned out it was a de novo mutation.
Yeah, it looks like it's a de novo because grandfather is negative, mom is negative. I think the testing for father is still pending, but there is no family history of seizures on father's side, so I'm suspecting that's going to come back negative as well. So it's most likely a de novo. Any other questions? Anything, somebody on online? I can't see if anybody had online. Yeah, okay. All right. Well, thank you.